Welcome, and thank you for joining us today for our webinar, Women in Caregiving, Supporting Children with Narcolepsy Through School. I am Dr. Irene Aninye, Chief Science Officer for the Society for Women's Health Research. SWHR is a national nonprofit dedicated to advancing women's health through science, policy, and education while promoting research on sex differences to optimize women's health. We are pleased today to have three distinguished panelists joining us for this event. Dr. Anne-Marie Morse, Director of Child Neurology and Pediatric Sleep Medicine at Janice Weiss Children's Hospital, Geisinger Health System. Dr. Erin Leishman, Senior Research Psychologist at St. Joseph's University. And Tammy Anderson, Assistant Director for Wake Up Narcolepsy. I would also like to thank the sponsor of today's event, Harmony Biosciences. SWHR maintains independence and editorial control over our program, development, content, and work products. We will be live tweeting during the event today as always and invite you to use the hashtag SWHRTalksSleep on all social media. Sleep is an essential function for overall health and well-being and aids in the body's ability to maintain proper brain function and physical health. As a result, individuals who experience poor sleep are more likely to report chronic health conditions, mood disorders, and neurodegeneration. Sleep disorders disproportionately and differently affect women and girls. Narcolepsy is a neurological disorder that affects the brain's ability to control sleep-wake cycles. There are two types of narcolepsy. Type 1 typically presents with excessive daytime sleepiness and cataplexy, or low levels of a brain hormone called hypocretin, while type 2 occurs without cataplexy and has normal levels of hypocretin. The exact cause of narcolepsy is unknown, and symptoms can start in childhood or adolescence, going undiagnosed or misdiagnosed for years. While the primary symptoms of excessive daytime sleepiness, disturbed nighttime sleep, and hallucinations are similar for adults and children, the appearance and expression of these symptoms are often different for pediatric patients. For example, hyperactivity, difficulty regulating emotions, easily distracted, difficulty thinking or remembering, and impulsiveness or restlessness both during the day and at night. Cataplexy is a sudden change in muscle tone that results in weakness or involuntary movements in one or more parts of the body, which can be triggered by strong emotions such as fear, anger, stress, joy, or laughter. Children may display atypical presentations of cataplexy, for example, facial, jaw, or eyelid weakness, tongue protrusion, neck extension, or slurred speech. There is currently no cure for narcolepsy, but with proper treatment, a child's symptoms can be stabilized. It's important to find the right clinical team, support resources, and treatment regimen to optimize your child's growth and quality of life, both at home and at school. Today, we have our three experts who will share their professional and personal expertise as we engage in this important discussion about narcolepsy in children and the role women often take as a primary caregivers in the family. Following our speaker presentations, I will moderate a discussion with our panelists, so we invite you to use the Q&A function to submit questions throughout the event. We will try to address as many questions as we can during this program, focusing on submissions that cover reoccurring themes or questions with a broader applicability to the audience. And so at this time, I'd like to introduce Dr. Anne-Marie Morse to talk about diagnosing and managing narcolepsy in children. Thanks for joining us, Dr. Morse.
Thanks so much for having me. Let me get these slides up. Sorry, hold on one moment. Right. And can everyone see my slides?
Yes.
Wonderful. So thank you so much for having me. I am a pediatric neurologist and sleep medicine specialist, and I do have the privilege of being able to partner with individuals who have narcolepsy from childhood through adulthood. And so with that, today we're going to have this zoomed in focus on narcolepsy in children and adolescents. What has already been highlighted is that it is most likely for a person who has narcolepsy to develop symptoms during this really critical developmental period in their life. However, recognizing that narcolepsy is a chronic disorder, it is important to recognize that it is something that's going to be hugely influential over the course of their entire life. And so with that stated, I very frequently will reference the fact that an individual with narcolepsy is on a journey. It is our medical journey. And with that stated, the journey can have a variety of different appearances. And it's important to kind of contextualize this to identify where a person may be at and how those can impact where we are currently and where we may be along the entire way. And so with this, there's a little video that I kind of have developed to help in illustrating what people may be experiencing. There's a period where you have no symptoms, and then there's this development of something that has changed. It may take a variable period of time of identifying that it's actually a problem, and then going to actually try to identify what exactly is occurring. During that period, it may actually be a really challenging time where the person may be now developing symptoms that have been already highlighted: excessive daytime sleepiness, cataplexy, disturbed nocturnal sleep, sleep-related hallucinations, sleep paralysis. But those symptoms can go beyond that, where you can have manifestations of the sleepiness as irritability or mood changes, hyperactivity, difficulty focusing, all the while accumulating other social challenges, becoming socially isolated and marginalized, having difficulty in school, being labeled as lazy or even quote unquote stupid, not trying hard enough, being accused of, are you on drugs? What exactly is going on here? Why don't you care all of a sudden? There also can be other biologic changes that occur during this critical period of time, such as changes in development of puberty too early, increase in weight, and a variety of other things that can change. With all of this, there's going to be seeking out a variety of different medical opinions. And during that time may come with being dismissed, having missed or misdiagnoses. What do I mean by that? Being told this is normal. They're a teen. Of course they're taking a nap. Oh, it's just an irritable teenager. Or perhaps you have ADHD. Here's a stimulant. And although that they may modify the symptoms, it's the wrong diagnosis, and therefore delaying getting to that right diagnosis to explain all of the symptoms. And sometimes it might be actually diagnosing a true comorbidity that may be present, something like sleep apnea, but still a delay to ultimately getting to the right diagnosis of narcolepsy. Why is this really important? This is important because we start to self-identify based on all of these different characterizations and stigmas. And this is all going on in a very critical period of life where this is going to dictate how we are for the rest of our lives. Delays in diagnosis and adequate treatment can really not only impact the child or adolescent during that period of time, but also predict the other areas of success in their life. What is going to be their academic success, going to college and being successful in college, achieving a higher earning job potential, getting married, having a family. So it's critical to think about this as a lifelong journey so that we're not getting stuck in a dismissed, missed, and misdiagnoses. And although it may be delayed, being certain that we're continuing to have this determination to find the right healthcare partner and social support to continue to make those strides to get to that point of a life worth living. The reason I give this illustration is because of the fact that with a chronic medical diagnosis, it is not just this one thing happening at this one time, but recognizing that all of this diagnostic journey that you're going through is also occurring in the context of normal expected developmental changes. And so, although there may be delays, and although there may be metrics that we measure to say we're successfully achieving certain things in life, such as we're making friends or we're getting good grades, it's important to contextualize that over the course of time. And these are all going to make really, really important considerations around how do we treat the whole person. Today, we're zooming in and focusing on the academic success. However, it's going to be equally important as we frame out the academic success and what we can do to help a child or adolescent be most successful in school, to recognize all of these other things that may be going on. We want them to not only be successful in school, but also be able to prioritize the things that are important to them. Were they playing guitar before developing symptoms and no longer have the energy or interest in doing it? Let's get them back to finding a thing that brings them that thrill. Are they at a critical period where puberty may be occurring? Are they starting to date? Thinking about driving or getting prepared for college? These can be daunting, especially when we start to replace all of the features that we had considered as a part of our own design as not no longer being a part of what is innate to us. What do I mean is that if I used to be the athletic person who was super outgoing and got good grades and was proud to have a fit physique, to now having struggles with being able to even think about going out with friends, never mind actually doing it, trying and being happy with just being able to sustain C's, or perhaps not even being able to think about what will college look like. These really become really critically important because it is something that is going to allow for us to really design a strategy between a professional and a family and child to identify what is the best treatment outcomes. It's important to recognize when talking about the symptoms of narcolepsy that they fail to truly capture the all-encompassing ways that narcolepsy impacts every area of life. When we talk about excessive daytime sleepiness, we many times are measuring up by things like the Epworth Sleepiness Scale. And because they're validated scales that we can reproduce and use in clinical trials, we tend to prioritize them as a metric of saying we're getting to success or we're not. But the reality is that when we're talking about a teenager or an adult or a child, and there are so many significant changes that are occurring in that period, it is important for us to restructure what our expectations and goals are. There are biologic changes that are naturally occurring, irrespective of narcolepsy, in terms of sleep-wake changes. There are also other brain changes that are leading to how we're going to have emotional maturity, how we're going to have judgment, what our executive decision or our cognitive function is. But there's also all these other uncomfortable changes that may be occurring, such as hormonal changes or body changes, that now I'm adding another layer of complexity that I need to figure out how to cope with and manage. Psychological equipment to be able to undergo all of those changes just without a chronic disease is hard enough. Layering in a chronic disease like narcolepsy that has so many palpable changes across 24 hours becomes really important. This manifests across also social and school environments. It is really hard to maintain good self-esteem. We recognize in that middle school, high school period, it is a really prime time that we're seeing lots of bullying. When adding in changes that we can't even explain for ourselves, it really is important to help in promoting adequate self-esteem. When you layer in these diagnoses that may have had a delay, we may sometimes start to identify as that clumsiness, which is actually cataplexy, is a part of who we are. Or I need to try harder, or maybe I'm just lazy and just don't have the same enthusiasm as previous. We want to make sure that we're capturing that self-talk that may be negative and helping to reframe it in ways of what is opportunity. We also want to equally prioritize the academic success with the social identification and friend environment, as well as family support. It takes a village to be able to support a child who's undergoing all of these changes and being able to help them be most successful. Today, again, we're going to be prioritizing the school environment and thinking about not only the academic success, but all of the other things that may be going on. We want to be mindful of the reputation a child with narcolepsy may have, especially if they go undiagnosed for a period, as perhaps the child who maybe just is not interested in falling asleep in class and maybe is getting reprimanded for that, helping them to reframe that reputation of that this is a chronic medical condition, no different than how seriously you would take a person who has epilepsy. You would want to make sure that you're taking a person with narcolepsy with just the same seriousness, and recognizing that it's not their choice to fall asleep in class, but perhaps a sign of struggle and inadequate treatment, and therefore an opportunity to intervene. When we look at the impact of narcolepsy, it is really important to really raise attention that it's not something that is optional to treat. And in fact, when we look at studies that have evaluated how this impact is on not only the individual, but also the family, we see quotes like this. When my narcolepsy was at its worst, I'd say I couldn't function very well. I didn't really have my best friend anymore. And I wasn't as close to people and I lost all of my confidence. This statement fully embodies the consequence of when these diagnoses are inadequately treated, are not diagnosed, or perhaps are not being given the right anticipatory guidance as to how it may impact and what our treatment goals need to be. We look at parents' responses. I've heard him say things like, I don't have any friends or have only one friend. And I think he wishes he could have more friends, that people liked him more and was more likable. He doesn't believe that he's likable, but I also know that he just believes he's completely different. He has narcolepsy. people look at him differently. He feels pretty strongly about that. It's important to see that this is a psychological opportunity to be able to help an individual adjust better to a chronic diagnosis and then optimally treat, removing the marginalization and really helping to reduce the likelihood of developing adjustment disorder with depressed mood or true major depressive disorder. With having narcolepsy, it gives my mood a boost in a bad way, I guess. So in the morning, I'll be sort of moody towards my parents and my brothers just because I just woke up and I don't really want to wake up. Almost having a resentment for being awake, which then manifests to others as though that I have resentment or anger towards you. She struggles a lot with anxiety and depression. Truthfully, at the beginning, when it was undiagnosed, I couldn't handle it. I could not handle the pressure of being the person that she was always crying with. She'd get that look on her face, and then she would tell me how bad her life was. It's important for me as a physician that I recognize that when treating a patient who has narcolepsy, especially in childhood and adolescence, I'm also treating the whole family. It is an adjustment disorder for the whole family to help in being able to be best prepared of how can we be supportive in totality. It really it lowers my, I guess, willingness to do those things that when usually I would love to do them. I really can't play basketball for long periods of time without needing a nap. And sometimes that can get in the way. So the main point that I want to illustrate is that this is a journey and it really requires a totality look at all of the areas of life. Academic success is a part of it, and being able to engage everyone who is involved and really supporting a child or adolescent in their journey is critically important. And so it's going to be really exciting for us to be able to kind of frame out, yes, this is the burden that a teenager or a child may be experiencing in all of the ways that it can look. How can we frame out a treatment strategy that it's incorporating things beyond pharmacology, such as 504 plans or individualized education plans? And what does that social support and strategy look like? And I feel so privileged to be able to be a part of this panel with a very experienced psychologist, as well as a parent with a child who's navigated this successfully, so that it really helps us all to learn something, to be able to allow no child or adolescent to be left behind from getting that adequate, total, comprehensive treatment approach for narcolepsy.
Thank you so much, Dr. Morris. This is a wonderful stage setting for our next speaker. And I do want to note that those who are tuned in live can submit questions at any time using the Q&A function, and we will try to address as many as we can during the panel portion of the event. And so now we will bring on Dr. Erin Leishman, who will discuss navigating narcolepsy at school and considerations and processes for academic accommodations. Thank you so much for joining us, Dr. Leishman.
Thank you so much. I'm so excited to be here. Let me put my slides up. Oh. All right. Can everyone see my slides?
Yes, we can.
Okay, great. So first of all, I'm so excited to be here today. I have a background in pediatric school psychology with a specialization in behavioral sleep medicine. I have no financial disclosures for this particular presentation, and I just want to thank everybody for inviting me here today to talk about what narcolepsy can look like in school, which I think Dr. Morse did an excellent job of providing an overview of, how schools can support children and adolescents with narcolepsy, and things that families should know when communicating with schools and across systems to support their child or their teen. So in our time together, I'll give a bit of an overview of before diagnosis and treatment, once you have a diagnosis, particular supports that you can access in the public school system in the United States, what you might want to think about when going into a meeting, some specific supports, and as well as some take-home points. So before diagnosis and treatment, I think that Dr. Morse did a really good job of talking about what the possible misdiagnoses and what narcolepsy might look like at school. So it might not be just the typical excessive daytime sleepiness and the fatigue. When kids are fighting to remain awake, they might be very irritable. It might look like a mood disorder. There might be an increase in impulsivity. It might look like they're not motivated or potentially have ADHD. And most specifically, like in school, how are you going to hear about it from the teacher? So it might be a formal or informal process. Your child might be getting formal discipline referrals. So they might be getting sent to the principal's office. You might just get a call or an email from the school. A lot of classrooms now have classroom behavior apps, so you might be getting notifications on your phone. It really depends on how your classroom is set up. They might be having frequent trips to the nurse, and teachers, again, might be noticing episodes of cataplexy, and they might not know what it is. If it was a full episode, I would imagine, and they did know what it was, I would imagine they would call the nurse or 911. But it might also present as, problems with facial expressions or tongue protrusion, as discussed previously. And that might be perceived, again, as an attitude or not being interested or not paying attention. So as we also discussed, there might be a really long time before you get the right diagnosis. So you might have to wait a really long time to get a referral to a pediatric sleep center. And then once you're at the sleep center, you then might need to wait a really long time to get a sleep study or a nap study. So what do you do in the meantime? So the first and foremost, I recommend starting some sort of record. So what are the teachers telling you? When are they telling you? How are you getting this information? Can you start a homeschool note, some sort of formal system between you and the teacher about what they're perceiving the problem to be? Create some sort of record of how much instruction the child is missing, because that will be helpful if the presenting concern is, Joey really has difficulty in math class. But then what you're realizing is that math class is in the morning and Joey's really, really sleepy in the morning and so isn't doing very well in math. It might not be a math problem. So just start doing these things for yourself. You can email yourself, you can email a friend, you can do it in your notes app, whatever is easiest for you to start some sort of recording system, that would be best. And then also you can ask specific questions about your child, which is obviously very important, but also you can start asking questions about the school and how they do things. So you can ask what their pre-referral system is. So what that means is what does the school do before they are formally recognized as a student with a disability or needing formalized or legally mandated services? So do they have a pre-referral intervention team? Is there going to be a meeting? Are there universal or targeted supports already embedded in the school that your child can benefit from while you're waiting for this medical workup on the other side? Because while you're waiting for the medical workup, obviously your child is going to need some sort of help in the school. Okay, so you've done all of the work and all of the waiting, and you find out that your child or your teen has narcolepsy. So what's next? So first and foremost, you and your child are the experts of your child, and that is across systems. So the physician might be an expert in narcolepsy, and the teachers might be the expert of their classroom, but you know your child. And then very quickly, you'll probably realize that your role as expert of narcolepsy in the school, because in all likelihood, your child might be the first student that they have worked with or made a 504 plan for or made an IEP for who has narcolepsy. Now, that's a huge burden. It's a burden of disclosure for you and your child. It's a burden of education. And once at least 1 or 2 point people in the school know about this information, they should be able to help you disseminate that information to other people who need to know. But you're going to be the person probably relaying a lot of this information to people. It's also important to know when you're interacting with schools kind of what they can do, what they can do, cannot do, and what medical professionals can. Okay, so medical providers. So they can provide diagnoses, they can write orders, they can write letters with your permission to the school. They can make very specific recommendations in those letters for these meetings, or even if there is no meeting. And that is hopefully after speaking to you and your child about what they want at the school. So they might not want certain things disclosed, or they might want certain types of supports. And so the medical provider or like a nurse in the medical provider's office can incorporate that into the information. They can also, they might not be able to attend every meeting or call every school provider, but they could also probably help you provide some information or some psychoeducation to the school personnel about overall how narcolepsy is going to impact them at school, or how it's possible. What they cannot do is order or prescribe an IEP or a 504 plan, or be very specific about how those things are worked out. So I mean, I don't even know how many physicians even use prescription pads anymore, but I've seen on a prescription pad, give Joey an IEP, or send for evaluation. I think so that gets photocopied, it goes right in the record, but it's not sufficient to have a school provide those supports. So a school personnel, so with your permission, they are able to also communicate with the medical providers. They are also able to provide eligibility determination, whether or not they are eligible for a 504 plan or an individualized education program. Now, the IEP or individualized education program is under special education law, and that is it's a more thorough process, and they will need your permission in order to do any sort of evaluation for that. But with the 504 plan, anybody can recommend somebody for anybody in the student's lives can recommend somebody for a 504 plan and start that process. The other thing that they can do is an individualized health plan. Now, this is not in any sort of federal law, to my knowledge, and I think different states do it differently, and School Nurse Association has a different view on it than states, but what it is a plan for a student that needs any sort of health accommodation. And you don't need to have a 504 plan or an IEP or be eligible for special education in order to have a health plan. It's really good for communication, and it's good for just having being able to disseminate your child's health information to the people who need to know. So for example, the bus driver for your particular child, the bus driver might need to know what to do should your child have cataplexy on the bus, just as an example. What schools can't do is that just with a diagnosis, automatically qualify them for special education or 504. And they can't do any communications without your permission or conduct an evaluation. What they both can do is listen to you and your child as experts, communicate with one another, as we said, and really work together to the best of their abilities to set your child up for success, providing recommendations for external resources in the community. Okay, we talked about this a very little bit before. These are the types of things that your child might be eligible formally in U.S. public schools. So 504 plans, these are educational accommodations. So there's no change to the curriculum. They are just supports to quote unquote level the playing field. You might hear that a lot. So it's a modification to the environment or the instructional delivery of the curriculum as it is, so that your child can access the curriculum in a way that is fair. An IEP is under special education law, and that is if your child is determined to be eligible and have a disability, an educationally classified disability, and that it impacts their education such that the curriculum needs to be modified. And then the healthcare plan is what we talked about before. So meetings. Now, meetings can be very intimidating. Although everybody is there to support you and your child, it's often you, sometimes your child, sometimes somebody that you've brought just to kind of hear what else is going on. But it's also a lot of school people, and they know all of the jargon, and they know all of the words, and they know what happens in the building. So it can be kind of intimidating. Different people that you might want on your team, or you and your child, obviously, any type of school personnel. So it could be a teacher, it could be a school psychologist, it could be a school counselor, the principal, the 504 coordinator, a special education teacher, any sort of related service provider. So OT, PT, depending on what your child might need, but also any coaches or aides or cafeteria workers, bus drivers. Like, there are a lot of people that potentially interact with your child, especially as they get older, and they don't have one teacher, they have 5 to 7 teachers plus their coaches. So lots of people involved. Just some hot topics here. I've in my gleaning of the information that is out there online, it sounds like it's a good idea to get accommodations early, because what that can, if your child is eligible, because what that can do is it can set up a record such that when your child is potentially looking for testing accommodations, for example, for something like the ACT or SAT, a more high stakes test, which is separate from the school process, you have a record that your child has required and used these accommodations previously. So it's not just out of the blue. Also, people say no before you go. So I think that even though they might be the experts on, they being the school personnel might be the experts on exactly what they're going to do or what they're able to do, you can have an idea before you go of what is problematic for your child, what they might be struggling with on their worst or most challenging day. So even if, like, you know, on one morning they aren't able to take their medication, what would they need to get through that day? And getting information from as many people as possible to support what you need. You can get that data from the teachers that we talked about earlier. You can get a letter from the sleep specialist, and then obviously your input from any other provider. Okay, so specific supports, I'm not going to read 100% of them. There are a fair amount of them online, but when you're considering them, and when they are written out, have them be as objective as possible, articulating the purpose of what it's for. Consider when, where, and under what conditions problems happen and where the supports are needed. So this could be behavioral, it could be academic, it could be social, it could be in any area that impacts accessing school. What are triggers? So, like, as an example, what might a child's trigger for cataplexy be? Can that particular thing be modified or supported? And who will initiate these accommodations or modifications? So a young child, it might be really on the teacher to do frequent check-ins and support in that way. But as children grow older, and in teens, it might be on them a little bit more to advocate and say, okay, well, I really need, you know, a cooler environment. Can we move that fan over here? I actually get extra time, you know, things like that. Okay, so the specific supports, again, I will preface this by saying there are a lot of lists online. We'll run through these really quickly. So with regard to excessive daytime sleepiness and cataplexy, might need scheduled breaks, movement breaks, scheduled naps, time for naps. Overall, I think that it's really good when you're working with a school to try to figure out what is in place already, like what structures are in place in the school building that you can capitalize on. So for example, for naps, is there a cot in the nurse's office? Is that available for naps for specific times? If your child has cataplexy, how can you build in, you know, if there's a fire drill, like, does your child need a buddy, and in what way can that be supported? And again, you would really want to work with the medical team about that with regard to what needed to happen. In terms of time, so a lot of the accommodations are regard to time and timing. So times of tests, scheduled breaks, can you chunk it? And then with regard to, like, is there preferential registration? Can you do homeschool, communication, and online learning? And then also not forgetting about the social emotional aspects. Is it possible for your child to get a related service and talk to the school counselor? Is there already a lunch bunch going on so they have social skills supports? What can you tap into that's in place in the school already? And then what individual things need to happen for your child to be successful? And then in adolescence, again, Dr. Morse touched on this a little bit. Narcolepsy, using the same study, narcolepsy can define their social lives, and thinking about in adolescent transitions to independence, self-advocacy, and importance of social time and acceptance. And then just finally, think about your expert role, building a team and communicating across folks, documenting as best and as clearly as possible for yourself and for your child, and really working towards self-advocacy and switching yourself and your own role from caregiver to care partner as your young person ages. Okay, and thank you so much. I can't. That is all for now.
Thank you so much, Dr. Leishman. I'd now like to invite Tammy Anderson to discuss her personal experience as a mother of a child living with narcolepsy and share insight into resources available for caregivers. We've also dropped into the chat some additional resources for family education.
Thank you. That was a beautiful preface to what I'm going to talk about. And I hope that you'll hear those pieces as I share the story of my daughter. So first of all, I'm with Wake Up Narcolepsy. And what is Wake Up Narcolepsy? We are a 501c3 organization that's dedicated to driving narcolepsy awareness, education, and research towards better treatments, eventually a cure, because we want for our children. But most importantly, I am Hero's mom. And yes, her name is Hero. And we went back and forth on that for a long time. It has been so fitting in her life. So I'll tell you her story, how we came about a diagnosis, when everything kind of happened, the symptoms we saw, and then go into the support that she's received and how you can access support for yourself or your child. The summer of 2015, Hero was 9 and a very typical kid. You can see the picture where we just had done a fun run as a family. And I will point out how skinny and tiny she is in that picture, because part of her symptoms brought on a lot of weight gain. But she did fun things. She was outgoing, very lively, kind of life of the party kid, and you knew she was around. She had a strep infection that summer, participating in theater, and it kind of went through the theater camp, and all the kids got it. I didn't think too much about it. We started some antibiotics, and she recovered very quickly without any problems. Looking back, I can see that that was the trigger for her narcolepsy, but at the time, it wasn't significant and did not come into my thought process of that might be part of the following symptoms. So into the fall of that 2015, we were at the pediatrician's office for another visit, and I mentioned Hero seems really sleepy. She's falling asleep in school, missing some activities, and the provider said everything looks really normal and healthy. Maybe she's bored. She sent us home with a wobble cushion on an Amazon order. Here are some ideas. Well, a couple weeks later, we were back for something different with another kid. And I said, it's not helping everything. She's just getting more sleepy. And I'm grateful for a provider that said, I don't know what this is actually, and we should just refer you. And I'm grateful that she recognized her own lack of knowledge in this area and sent us on. So we saw the sleep clinic. And when we went, they said, there's lots of things that could, we did all the screens, and they said her symptoms match for something. It could be iron deficiency, obstructive sleep apnea, or it could be narcolepsy. Well, what did I know about narcolepsy? I maybe had seen it on TV one time and knew the word, but kind of had maybe a stereotype in my mind. And it didn't look like what we were seeing at home. So that was they didn't give it a lot of weight in that visit. And so I dismissed it pretty quickly. And we decided to go with iron therapy because she was iron deficient. Not realizing how long that might take. We did iron therapy for a year. And at some points, it looked like maybe things were improving. We hit summer and she was active and doing things. Now we know she wasn't sitting in a classroom. And so that was probably more the cause of that alertness versus that the iron was being effective. Back to school, and in the fall, she was asleep again and more. And we were seeing symptoms of what we didn't know at the time was cataplexy. So we had the recommendation to do a sleep study at that time and decided that was a good idea. And as sometimes sleep studies can take, get scheduled out several months, it was January before we were able to do that. And it was very conclusive that she had narcolepsy. This cute picture right here is the first day that she met her sleep provider, and we were able to get some meds started. And again, she had this wakefulness that we thought was the answer. Just give her a little bit of medication and it'll be fine. But because she had been so tired, this wakefulness wasn't her optimal wakefulness. We had to start learning to do life again. She had slept for 18 months, basically doing minimal life tasks. Really just whatever she enjoyed doing and could do is what we let her do. We didn't force anything. School kind of just got set aside. If she was able to do something or we were able to read something to her, that's what she did for school. We had to start putting schedules and accommodations and scheduled naps and figuring out more medications once we realized that this actually wasn't the cure that we were looking for. Some things that we learned is that it takes time, changes over time. The same therapy is not going to be a one and done, and it doesn't look the same for everyone. Fast forward 8 years, and she just graduated. She turned 18, got her driver's license in December, and has done very well. We have had great doctors that have helped us along the way. Her school looked different. Prior to narcolepsy, she was doing a private and cooperative school. Like I mentioned, she had to stop doing school because she was so tired. It was an easy system that we were in, thankfully, and we had supportive teachers and administrators. So we took her out and homeschooled her until we had a therapy that was working effectively. Once she was doing well, we put her back into a cooperative setting with homeschool online combinations, because not all classes were successful in a school setting, even with medications. Then we hit COVID and went homeschool full-time again. And then we were able to put her into early morning classes in 2022 at the local school and do online concurrent enrollment for the afternoon classes, because her teachers sometimes don't believe that she has narcolepsy, because at 6 o'clock in the morning, Hero is awake, but it doesn't last long. So about 6 to 9 is very optimal for her, and she's able to get some good solid work in there. And then online classes allow her the flexibility to take a nap or take breaks as she needs to. I think we had a great coverage of school advocacy. I think modeling respectful advocacy puts your child in a very good place to advocate for themselves, and modeling that and allowing them to participate. Being available to help your child with their homework. And I know for us, text to speech and speech to text for notes and papers has been very helpful. And Wake Up Narcolepsy has some other information on school accommodations at the QR code there. I want to talk a little bit more about the support at home. If you see this depiction, being deliberate versus accidental, if Hero takes an intentional, deliberate nap, it's 15-20 minutes and she's ready to go again. If she falls asleep, it could throw off the rest of the day. So just being very encouraging of deliberate symptom management has been a great tool. She's not always receptive to it, but I think she's learning that is the best way for her. Physical activities whenever possible. Instead of doing family movie nights as regular as we used to, family walks, things that will engage her and where she won't self-isolate because she knows she's going to fall asleep and she's going to leave the activity and just not participate. I would if you had a doctor like Dr. Morse, would you not keep every doctor's appointment? I think seeing your specialist regularly and keeping those follow-ups so that they can help you. You may not always see the difference between their wakefulness and that decline, and those small adjustments, and a provider asking you, saying, oh, you were doing like 5 things when we last talked and now you're only doing 3. Is that because you're more sleepy? Really just work with your provider to keep on top of the meds and give your kid the best life that they can have. I think giving some attention to a mental health provider, having that conversation can be huge, and they can bring in pieces that maybe you're not seeing, and maybe hopefully eliminate some stress in the situation if it becomes burdensome for yourself, because we know that that's an extra burden to care for a child with a chronic condition. Choose fun and prepare for the consequences. This last week, Hero went to a youth camp all week. I know this week is going to be just a crash, and that's okay. I want her to have fun. I want her to enjoy the activities that she wants to participate in, but I'm going to prepare and know that this week I'm not going to ask her to do as much as a normal week. So I truly believe that to ease the burden of a parent, we have to ease the burden on the child. And Wake Up Narcolepsy did that for our family. We attended the Narcolepsy Family Weekend that first year that Hero was diagnosed, and she felt connected. She felt understood, and her whole trajectory changed, and that lightened my burden. I've been able to attend support groups, get education from the webinars, just so many things that have really lightened her burden and lightened my burden. So I would encourage you to check out the resources that we have available at Wake Up Narcolepsy. And just thank you for letting me be here and share with you today.
Well, that's just, thank you so much for sharing your story and how you got to this place. We know it's an ongoing journey. Thank you so much, Tammy, and everyone for what you've shared. And so we are going to enter into the panel discussion portion of this event. And so I invite you to turn your cameras on. Again, we invite attendees to submit questions using the Q&A function within the webinar app, and we will try to address as many questions as we can during the next 10-12 minutes of this program. Please note that our conversation today is intended for educational purposes and is not intended or implied to serve as a substitute for medical or professional advice. We encourage all patients and caregivers to confirm information with their and consult with their healthcare providers to determine individual needs. And so to open up this conversation, I want to dovetail a bit on what you mentioned, Tammy, and maybe Dr. Morse, you can chime in a bit. How did you, or what strategies did you use to prepare your daughter for this medical journey with narcolepsy? Did you ever kind of like look ahead, and then we'll start with Tammy, then maybe Dr. Morris, what strategies or what have you said to families to help prepare them along this way?
So actually my husband is a genius, and I think like I'm the mom and I have a degree in child and family development. Like, why do I not think of these things? That Hero, he would always have her prepare questions for her provider before we went in. And he would just really talk to her about like, what are those challenges? What are the things you want to know from her first visit when she was 10? How are you going to talk to your doctor? And we had an amazing doctor who would talk directly to Hero. And so she just really learned that it was her conversation. This is her diagnosis. We're here to support you. We've got your back, but you need to have these conversations. And so that's what I encourage other people in the school setting with your provider. Your kid has to learn how to speak for themselves. Of course, I jump in at times and share, and but now at 18, I just basically sit there and smile, and I'm just proud of her.
You know what I love about that introduction of how you did that is you first framed it in, I have the right academics to be able to navigate this, but it's dad who was able to do it. And the reason I want to just highlight that is because For myself as a physician, and when I'm speaking to my medical students, residents, or other physicians, it is giving that call to action of that, although we many times are leaning into our academic brains and think that we know what's best, it is a clear illustration that the parent's brain, knowledge, awareness of their child, and what the intentions need to be in order for there to be a successful ecosystem needs to be honored, right? And so when we move away from the framework of thinking that everything has to fit into this academic box and actually realize that we are people treating other people, then it allows for us to actually rely on what I actually lead with when answering this particular question, which is emotional intelligence. And so with that, Tammy has actually even relayed that of saying, what is your self-awareness? What do you know to be a problem for yourself? How do you currently manage that? That's that self-management. And then for others to go, what is your social awareness? Do you realize what your interaction with other students, what your interaction with friends? Do you realize how are you managing that? Are you coping well with that? And so for me, I very frequently will talk about, I like for people to keep a symptom diary. And I move away from being a sleep physician that tells you to keep sleep diaries, because I believe by telling people to do that, I'm making the same mistake as the rest of medicine of saying, I only care about wakefulness. I only care about what you do during the day. If I only ask you questions about how you're sleeping, are you having sleep paralysis? Are you having all these other issues with your sleep? I fail to acknowledge all the things that are a priority for everyone on earth, which is what I do when I'm awake. And so by understanding that symptom diary at baseline before treatment, it allows us to now frame up what would be a treatment goal? What is tangible? What is important to you? What is it that you want to drive towards? That then allows us to have a realistic conversation of, this is the menu of options. What is the reality of the likelihood of us getting to that goal with each of these treatment options? And then what is the reality of you being able to utilize these treatment options? I also am very upfront with many people to let them know that at this point, polypharmacy or utilizing multiple medications is typically the rule, not the exception, especially for a disorder that affects 24 hours of your day. And so I generally like to complement that concept with the idea that my goal is to develop a treatment strategy that fits your life, not your life fitting a treatment strategy. And so I constantly try to drive at the empowerment of the individual and the family of being the drivers of all the things we do. And I just get to be this really kind of lucky individual that gets to partner and kind of say, these are our menu of options, and this is the risks and benefits of each. And you're describing that this is the outcome you'd like to see. This is what we can do, and this is the kind of progress map. This is when we're going to expect this benefit, and this is when we might see this side effect, and this is how we're going to measure the effect. I have found that that really starts to engage, especially my adolescents who may be struggling with acceptance of this disorder and many times want to try to do things without any medication because they're still so angry that their life has been so disrupted by this thing that they can't control. By really, again, putting it back into their ability to have the empowerment and for us to really partner, I have found to be incredibly successful for really engaging the whole family unit.
And so to that extent, as they're approaching these goals, Dr. Leishman, can you speak on how do we begin to course correct the perceptions and the labels that are attached to our young ones prior to getting this diagnosis? You know, we talked about they might be perceived as being clumsy with the cataplexy or having this attitude, and you can spend years kind of where they can also take on that identity and that perception. So how can we begin to course correct with our young ones, but then also with the schools or the teachers and the family members that might also, the parents that might have, you know, had some thoughts about what was going on in the years prior to diagnosis?
So I think that, like many of these things, a multi-system approach is really necessary. I think that in the school system. Hopefully there is a bit of health literacy. Now, narcolepsy specifically is so rare that it's unlikely there's going to be a specific program educating folks specifically on narcolepsy across all schools, right? But can there be a little bit of awareness built in with health education and health literacy there? Yes. Should there be people in school, if a teacher needs to reframe their thinking about a child's behavior because potentially it's bothering them, but really they need to kind of flip their thinking about what might be going on with the child. Hopefully there are school counselors and administrators who are supporting teachers to switch their thinking about that. And then also from the family side, if there are behavioral problems and health problems going on, it's unlikely the sleep specialist is the first person they're going to see because there is such a wait. So probably they're going to see a behavioral health provider first or a primary care physician first. And so in those spaces, they can help families rethink and have strategies in the meantime about how to support and think about what's going on with their child.
Thank you so much. I know we are coming to a close, and so I did want to wrap up with one last question for all of you. We often have patients and healthcare providers, researchers, policy professionals that all will tune into webinars like this. And I usually ask for a takeaway that each of you would recommend for one of those viewer groups. But today, I want us to end refocusing on the main characters of these narcolepsy stories, and that's the children. And those are our young ones. And so I want to ask each of you, what advice or words of encouragement would you give to a young person that is living with narcolepsy and either about to just found out or is in this journey currently? And so I guess if we can start with Erin and then Anne-Marie, and then we'll end with Tammy.
That's a good question. Find your friends and look for support with your family and your favorite teacher. I mean, I think that, and keep going because there is some support at the end and through this process.
So I would say that it's okay for you to go through all the feelings, go through the anger, the resentment, the periods of acceptance and cycling back through the anger. That is all very, very appropriate experience. What I would encourage is don't stay in the anger and denial. And the reason I say that is because being diagnosed with a chronic disease like narcolepsy, and at this point, it being a lifelong diagnosis, does not mean that you now have a glass ceiling that you cannot break through. I would encourage you to still maintain your same efforts, enthusiasm, identification of who you are and want to be, and utilize those and remind others around you of that's who you are and want to be, and allow for that structure and system to support you getting there. We are at a beautiful time in this condition where we are seeing only increasing number of treatments available that are really going to be incredibly transformative. And so my biggest point to make is do not lose the hope of living the life that you want to live.
Those are perfect. And I would just build off of that. Once you've connected with your family and friends and you've got your support system and you've kind of moved past and felt your feelings, and go find your narcolepsy tribe. It will change your life. Hero has met so many people, old, young, same age, and she keeps in touch with them. She's able to reach out to those ones that are ahead of her and say, what did this look like for you? How did you navigate this? And she's got the friends that she can text and say, I'm having a hard day, and they get it. And she doesn't have to explain it. She doesn't have to come explain it to me, who understands, but doesn't have that experience. And having your narcolepsy family will really change your life. And come and I'll give you a hug.
Awesome. Thank you so much. I'm hearing embrace your experience, remain hopeful, find your people, and find your tribe. These are so amazing. These are great nuggets. I encourage our viewers to share these sentiments with any youth that you interact with that are navigating their life journey with narcolepsy. And thank you so much to our panelists for your time, for your insight, for your transparency. You are all amazing. And thank you to Harmony Biosciences for their support of this event and SWHR's narcolepsy program. With the guidance of experts in our narcolepsy working group, Dr. Morse was a part of it. SWHR developed a narcolepsy toolkit, a woman's empowerment guide to provide easy to understand information about sleep health, understanding narcolepsy, the diagnostic journey and treatment options, as well as wellness tips. Although written with women in mind, much of the content can be applied to our conversation today in working with children with narcolepsy. We also have a poster specifically about supporting children with narcolepsy at school that captured the discussion we had today, as well as other resources for parents and guardians to help their children navigate care and support for their narcolepsy. You can download these and other women's health resources on our website, www.swhr.org. And we also invite you to connect with us on social media, sign up for our newsletter, or register for future events about topics such as endometriosis, menopause, Alzheimer's disease, obesity, bone health, and other topics. We will send out an email with a recording of today's webinar to all registrants, as well as post a recording on the event's webpage for future viewing. So please be on the lookout for that and feel free to share with others as we continue this very important conversation that hashtag SWHR Talks Sleep. Thank you for joining us today.